Very excited to introduce our next speaker, Dr. Yusuke Hamada. He's a fantastic clinician, head of grad perio at UCLA, somebody I call a friend, and he's just a great guy. So I'm going to go ahead and turn it over to him, and here we go.
All right. Thank you so much. Well, thank you so much, everyone, for being here. And the team BioXclude, especially Matt Burns, the best guy ever. So interestingly, I met BioXclude when I was first-year resident. I didn't think that I'm going to be here to talk about this product when first time I saw it and when I use it. So it's been a while, probably more than 10 years, decades of time. At the beginning, his name is Rob Toffee, came to our school to give a presentation of the product. You know, everyone goes to the school for the lunch and learn. Oh, our memory is best. You know, you should use ours. Super sketchy. No, I'm serious, because any single company, New York company, to go to the school for lunch and learn or corporate forum, well, even they couldn't do corporate forum. They didn't develop yet at the time. So that's why at the time, Rob Toffee came to the school. This is great membrane, helping the heating process, easy to handle, yada, yada, yada. I was so skeptical. But then we purchased some, then we use it. Okay, it's easy to handle, pretty nice outcome. It's been great. Then I'm into more. Then did a couple of studies as well with one of the researcher at the Indiana University when I was in Indiana. Then doing a lot of clinical patient care as well. So that's why I'm very honored to be here to talk about the periodontal regenerative procedure with BioXclude membranes today. So let's look at the patient first. This is like a typical incisor molar pattern patient, 18 years old, African-American male, had really deep intrabony component between number 9 and 10, 90 mesial, and also mesial number 30. When you look at closely clinical feature, there's a probing depth 10 to 11 millimeter with BOP on the mesial number 30 area, as you can guess this area. Oh. Yeah, this area. The anterior area, you see that huge bone loss between 9 and 10 here. So then after the 4 weeks of the SRP with systematic antibiotics, it's pretty typical treatment modality right now. Then we're going to move on to surgical procedures. Yeah, let's look at number 10, 9 and 10 area first. You know, you see the probing depths pretty deep on distal number 9, but at the time of the before surgery, we are looking for actually intrabony component only for number 9. However, once we open the flap, actually there's no bone on the number 10 mesial as well. It's quite surprising because we got a slight nice soft tissue attachment on this area. The probing didn't go through due to the presence of this bone. Then when you raise the flap, we clean up with a scaling loop planing all the way, utilization DDS solution just to get the modification chemically. Then we utilize RH-PDGF-BB plus FDBA to fill the gap or defect area. Then we utilized BioXclude membrane, as you see here. You know, just lay down, BioXclude membrane, lay down, put it in to get the primary closure here. Then lower right side, we did the same day to save patient money a little bit for the product-wise, because we can use the same bone graft materials, very tiny space with one BioXclude membrane is enough to use both sides. Elevate the flap, EDTA solution, grafting with the PDGF-BB. Again, amnion chorion membrane, BioXclude membrane was placed into the defect, get the primary closure. So then this is a pretty open, the 5.5 months, almost 6 months post-op procedure. You can see that slight recession is happening, but recession is not as bad as we expected. This type of the intrabony component, especially two teeth are exposed together, we tend to see more larger amount of decision. Then you can see the nice bone fill on the X-ray as well. Then, mesial number 30, around 6 months after, even you can see that nice soft tissue condition as well as nice bone fill. So this is pretty much predictable procedure for us every day. But why this is predictable? We need to think about many factors. For example, when you look at the factors for patient factor, local factors, and our clinician factors. Of course, patient factor includes systemic conditions such as smoking status, diabetic condition, plaque control, motivation, the financial availability too. Of course, we can put all the materials together for the patient who cannot afford it, unfortunately, at this moment. The local factor include the defect shape, gingival phenotype, keratin tissue, and gingiva, tooth mobility, the emphagation, etc. Then we need to look at ourselves very carefully. Operator factor plays a role. What do we know about materials? What do we know about surgical technique? What do we know about the instruments? So when you look at the historically speaking, these are the kind of key factors for me to get the periodontal regenerative procedures. Of course, we need to consider nice defect selection first here. You need to see nice interbony component containable defect, we need to use it. Then, of course, space maintenance is extremely important factor to allow cells to repopulate the area. Then grafting process, Dr. Bowers already showed that, as well as biological modifiers, including maybe at this moment people use EMD or RGA, BDGFBV, or maybe PRF, or etc. Then, of course, important factor is primary closure. How often do you see the best outcome that the wound is open after 1 week procedure? We barely see that. Means that the wound primary closure, especially nice, secured primary closure, is very important. Then needless to say that maintenance is one of the most important factor to gain nice outcome. But as a faculty at the school, not only private practice or not only clinical practice, I just want to discuss a little bit more biological concept before talking about BioXclude membrane. So, do we know how tissue heals? How much do we know about tissue healing process? We have to understand the tissue healing process a little bit before utilizing concept more carefully. It's a little bit off, sorry. So on the top here, there's information there. Then angiogenesis, followed by gradual tissue formation. But when you look at the right side of the picture, once wound happen, they get the blood clot formation first. Once the blood clot formation happens, they get a lot of cytokines plus a lot of oxygenated product, and new blood vessels go into the site to regenerate or to repair the area. So, based on this situation, when you look at this area, the first thing the body responds to the injury, which is surgical procedure, is inflammation. Then you see that a lot of factors coming in, then proliferation, migration of cells, then remodeling, and the reorganization, remodeling. Based on this one, we can say that these 6 factors are extremely important. First one is inflammation. Second, cell proliferation. If cell doesn't go proliferate, we don't get the healing. The angiogenesis is one of the most important factors. Without new blood vessels, soft tissue or hard tissue, nothing heals. The migration, cells are moving to the area to fill the space more. That's migration is important. Then differentiation means that those cells become different cells. Mesenchymal stem cells can be different cells, maybe bone, PDL cell becomes other stuff. Then remodeling happens to mature the wound. This is a basic wound healing process. So we have to understand this concept before talking about regenerative procedure around the teeth. This is a regular one. But compared to just regular wound process, when you cut the finger with paper and surround teeth, what's the difference? Presence of the tooth. Tooth doesn't give any blood. That's why we are dealing with biggest enemy, it's avascular surface. Therefore, historically speaking, regenerative surgical techniques has been developed in so many ways. Back in 60s, 70s, people pressed bone graft into the defect because there's no bone there. Let's put the bone graft. Second generation, around the 80s, GTL membrane came out to prove the concept of guided tissue regeneration, to exclude the epithelial ingrowth to allow other cells to repopulate from the other area. The third generation includes that the more biological modifiers, including EMD, VMP, RTPHPGBB, or PRF. So this level, we are looking at the molecular level, cytokines, growth factor to stimulate wound healing process. Then Daniel Kegler wrote a really nice paper about the PDGF-BB. This I like, everyone is familiar with tissue triangle, of the engineered tissue engineered triangle. So we need cells to heal. We need scaffolds and matrices to secure the space. We need molecular mediator to boost up the healing process. Then blood supply will be helpful to get the new blood, to give a nutrition, new oxygen to the area. Based on this, when you categorize different way, you see the cells on the upper left side, the fibroblast, gingival, or PDL are natural teeth. Maybe cementoblast, osteoclastic activity, osteoblastic activity. Then bone graft materials and the membrane will be playing the biggest role to secure the space, right? Then molecular mediator, at this moment, we know what we utilize is EMD, RHPDGBB, or FGF in some countries, the BMP2. We don't use BMP or natural teeth, but just a molecular mediator example, the PRP, PRF. That's why people are developing a lot of concept for regenerative procedure with cytokine development. But how about amnion chorion membrane? This is the most sketchy point when I saw first time. I'm serious, I'm sorry, but I trust now because the science came out more. So amnion chorion membrane could be utilized as a matrix or material as a membrane as well as molecular mediator. Let's talk about the BioXclude membrane in a little bit more detail. So where this is coming from? This is a company published picture, so this is not my own. So this is like an amniotic sac and the placental tissue. They get the amnion and the chorion layer of the membrane. So amnion chorion membrane or amnion chorion layer actually protecting the baby development. Therefore, they have to have protective barrier function, immunoprivilege, and the infection prevention to allow baby to grow healthy condition. Then, BioXclude always said our product has growth factors. Are you serious? That was my feeling at the beginning. But let's talk about more detail. So this is like a published paper back in a while ago, 2013. They look at the human dermal fibrous proliferation with extracted extracted BioXclude or ACM, let's say ACM for this paper. They compared the proliferation of cells affected by this ACM extracted liquid or media. What they found was that they increased the proliferation level to the certain level of the concentration of extracted ACM extract. Then they also look at the human bone marrow mesenchymal stem cell migration as well. What they found was that dehydrated ACM, amnion chorion membrane, aka BioXclude, they help migration of mesenchymal stem cells as well. So based on this paper, summarized in summary, extracts are made by means of a membrane that placing them in immediate soaked soluble factors. They contain growth factors, cytokine, and the regulator of tissue remodeling to help cells to grow, which help proliferation of cells, which help migration of the human mesenchymal stem cells, then increase stem cell recruitment. This is just membrane, we thought, but actually working as a biological modifier as well. Then this paper came from the Houston group. They look at the amnion chorion as an antimicrobial activity product. They utilize the porcelain collagen membrane, and this is ACM membrane. What they found was that you see the bacteria less growing around the ACM area. So based on this paper, they summarize that ACM completely inhibits bacterial growth at all time frame, whereas the PPCM means a porcelain pericardium collagen membrane. did not demonstrate any antimicrobial properties. Interesting. Again, this is a membrane, but shows that bacterial inhibition in this model. So these, we are reading these papers, very interesting, because again, first year, when I was first year resident, Rob Toffee came to school saying that this has immune function, antimicrobial activity, they help cells. Are you kidding me? But these papers are coming later on more and more. All right, so why don't we do studies? This study we run with one of the Japanese university, Dr. Imamura plus Yoshida. What we did was we purchased membrane. This is non-supported by corporate at all. So I can disclose that this study was completely independent study. What we did was that we smashed the ACM membrane into the PBS. Then they extract some debris from the area. The supernatant were extracted. The experiments are complete with different concentration of 100, 200, 500, or 1,000 microgram per ml of ACM extract. Just trying to mimic the condition that once ACM is digested in the body, how those affect the cells. So interestingly, first, the ELISA study shows that they found VEGF, which helps the new vascular formation. It's around 25 picogram per ml from 100 microgram per ml, the solution. Please pay attention to this picogram. Extremely low, right? Do you remember how far picogram will be from the, so far, right? Yeah, I know. I like that people say, no, I don't remember. That's okay. So they look at the rat periodontal ligament-derived cells to seed in the plate. They put the ACM extract as a media. What they found was that 100 micro per ml of this area actually promoting this, oops. Hold on, sorry. Yeah. They promote the proliferation of the periodontal ligament cells. So ACM extract actually helping or promoting PDL cells to proliferate. But actually more than 500 microgram of the ACM extract actually reduce it. Could be some sort of the maybe cytotoxicity because those are cell studies. Then when you look at the migration study, similar way, when you look at it, this is a 12 hours, 24 hours result. What we found was that once we utilize BioXclude extract, we see more wound healing assay-wise, faster wound closure compared to control group. So which means that we can draw the conclusion those BioXclude extract digested by body or some way can help or can stimulate migration of cells. If so, those cells can go inside the area faster to proliferate more to help the healing process. Then not only for the cell study, the group did the animal study as well. They look at the three groups. They created that there's a distal side of the molar, second molar to make a defect, mesial molar, first molar made a defect here. Then utilize unfilled only scaffold and ACM put in the root surface. Just put in the ACM into the surface, then fill with the scaffold itself. So unfilled, scaffold, scaffold plus ACM. What they found the histology was that in 2 weeks after, you can see that more bone fill compared to control or only scaffold. Even more 4 weeks after, you can see that this is notch, bone notch here, so which means the bone fill was way higher than only scaffold nor just a control group. But interestingly, we see that it looks like this area seems slightly ankylosed. So I'm not sure that the utilization of membrane itself on the tooth surface could be a good idea, not at this moment from this study. However, just these findings suggest that BioXclude promote the proliferation and the migration of PDL cells and angiogenesis, which lead to enhanced wound healing process based on this study. So again, this is a completely non-biased study. We purchased everything. This group in Japan got the grant to do this study, not from the company supported. So we don't have to, we are not biased. Then this study was done in Indiana. That Dr. Namakirik did a study with that what we did was similar way. We created ACM extract, then removed the debris. Then we created the 5 different concentration of the experiment extract. Then this time we utilized bone marrow derived mesenchymal stem cells, how they heal it. What we found was that higher concentration of the 500 to 1,000 micron gram of ACM extract actually help proliferation of bone marrow derived stem cells. They also, 48 hours, they have a similar tendency. In addition to that, mineralization assay after the bone marrow stem cells are used with after ACM extract stimulated cells, what we found was that we got more mineralization compared to lower concentration. So this means that the BioXclude extract, which means that digesting the body, will be helpful to promote even bone marrow derived stem cells as well. Again, this study, we didn't get any fund from this SNOESIS at the time from the BioXclude team at all. Completely independent study. So based on that, these findings suggest BioXclude promote proliferation and the mineralization of bone marrow derived stem cells as well. So based on this, BioXclude membrane, we thought we are using just a membrane purpose here to protect or to secure the space. However, these molecular mediators from the BioXclude membrane actually affecting these cells regards to proliferation, angiogenesis, migration of those cells, and differentiation of those cells later on. Therefore, we can get predictable regenerative outcomes. So we published a paper from the clinical advance in the periodontics way, like 4 years ago, yes. This patient, we got the huge intrabony defect mesial number 19, raising the flap. Then this time, we tried to utilize the BioXclude membrane as a growth factor, not only membrane. So we apply the membrane to the root. This one, please don't attempt in your patient tomorrow, because this is not fully set protocol. We're just doing experimental purpose at the time with IRB, just FYI. Then we grafted the area. Then we place the BioXclude membrane over the top. Then get the primary closure. So this is a regular surgical process. Only one difference is we try to use BioXclude membrane as a biological modifier. So what we found was that this is 6 months after, 18 months after of the clinical and the radiographic findings. Without histology, we don't know this is regenerated or not. Maybe ankylosed, maybe based on the animal study. The animal study and this study was going on together, so we don't know. We didn't know at the time what the possible healing process. But the clinical feature shows that a lot of small recession happen, but tend to be back. So this is the before and the after that we will maintain the tooth with nicer prognosis value. So let's look at a couple patients. So this is one of the patients we treated when I was in Indiana for 33 years female. Like previously called generalized aggressive periodontitis situation. So you can see that a lot of intrabony defect all the way around. So upper left posterior, lower left posterior, lower right, and upper right area. After scaling group plating, you can see that a lot of recession with the reduction of inflammation. So this is the way we raise the flap, complete degradation, bone fill, BioXclude membrane, close it, Similar way. This time we utilize PRF at the time too. Resident want to try something, right? Because when I was resident, we wanted to try PRF, just came out, pretty common modality. Then you can see that interbony component here, bone graft, you can see the BioXclude membrane here. So the 6 to 8 months after, 5 years after, so patient was coming to the maintenance almost every 3 to 4 months until COVID happened. Then you can see the 5 years after, very stable horizontal bone everywhere. It's pretty stable. Then this is 8 years after. So you can see that the bone fill was actually maintained all the way around. So patient was told at the beginning, patient might lose teeth a lot at the beginning, but 8 years after, probably just 1 to 3 millimeter, couple falls, brushing is good, patient improve a lot of oral hygiene. We converted prognosis from maybe questionable to at least fair majority of the teeth. So next one, similar situation. This patient actually we treated, when I was in Indiana, we treated with Dr. Lanlin Chow, 31 years female, similar way, interbony component everywhere. A lot of interbone loss all the way around. The similar modality, we utilize a non-surgical therapy with antibiotics, include amoxicillin plus metronidazole, regular combination. I have all the picture of the entire mouse. We completed the regenerative procedure for entire mouse, but just representing to talk about mandibular anterior area. So this area today. So you can see that a lot of interbony component, anterior area, as well lower right sextant area. When you raise the flap, you will see that irregularity of the bone. Full thickness flap was completely elevated, clean up everything as much we can. Then we fill with PDGF hydrated bone, FDBA. Then next step will be obviously BioXclude for me. So this is one of the characteristics I want to emphasize today for BioXclude membrane. Easy handling portion. BioXclude membrane like this, we just simply cut. Make a tiny strip. Then put each strip between the teeth like this. Then when you drop couple or 1 or 2 drop of the saline over the membrane, they fall down by themselves. Then just adjust the position with period probe. If so, you will see like this nice adaptation. So very easy to handle. Then they don't swell. So if you have a chance to stop by maybe booth tomorrow, day after tomorrow, you can try. Once you hydrate the membrane, handling properties changed, but they don't swell, unlike collagen membrane. Therefore, it allows me to get a nice primary closure, which is one of the important factors to get a regenerative outcome. Then this is a post 5 months, 8 months after. Of course, recession happens. Then this is 1 year after, patient brushing very well. Then you can see that 1 year after, whole entire mouth became flat. We did technically every single tooth, similar modality. Then this is 3 years follow-up. You can see this is before and after of procedures. All the interbony component was converted to flat horizontal bone. Why do we want to convert interbony component to the horizontal bone level with low probing depths? The one paper from Papapano shows that quite a long time ago. This is our only radiographic study. What they found was that the presence of angular bony defect entails increased risk of further alveolar bone loss. So once you convert from interbony component to horizontal bone level by predictable regenerative procedure, you can actually improve the prognosis of each tooth. Therefore, regenerative procedure will be very important to get the better outcome. Then next patient. So this is an interesting situation that we treated with Dr. Carson Hunt. He's at our resident we had a patient who had a huge radiolucency on the apical portion number 30 mesial here, which is actually extending to 29. So when you look at CBCT image, this area of defect almost encroach into apex 29. We are debating that should we remove 29 or it's coming from 30, so we should go 30 only. But the number 29 was vital at the beginning. So we discussed with patient pros and the cons. Patient decided to let's try to save 29. So we raised the flap. Then we extract number 30. But as you see here, this intravonic component through the extraction socket is completely connected inside. We debrided as much we can, clean up as much we can. Then we utilized PDGF-BB hydrated FDBA packing from the extraction site as well as intravonic component site. Then, of course, we utilize amnion chorion membrane around this natural tooth area. Then we utilize collagen membrane for the extraction site. So then this is just immediate post-op of the extraction site. You can see that the bone fill all the way inside where radiolucency was present. We follow up the patient 3 months. We number 929 maintained a vital tooth. Then we didn't see any problem depths anymore for this number 29 area where it has a bone defect. We are hoping that we took CBCT to plan for dental implants. You can see that bone fill without any void space, which is coming down. Then we utilize the STL5 plus DICOM data, implant position set. You can see the soft tissue thickness for this line is XB thin. Dr. Hunt raised the flap, placed the implant, the position where we want to. They utilize the radoma matrix to pump up soft tissue thickness on the back side. But again, there's no defect on the mid-29 still. Then healing process at immediate post-op. Then post-op 3 months of the implant placement. Again, 29 maintains vital. Patient's happy, we are so happy. Then when we look at soft tissue condition, pretty nice before sending back to the patient. This is before and after. So you see that the implant was placed nicely, then restored by general dentist to restoration. Again, and you see here PA for no more any radiolucency. Of course, we maintained vitality of 29. So when you see here, you can see post-operative regenerative procedure, recession went down, but we were able to bring back with another extra soft tissue treatment with saving 29 instead of 2 implants. So we can show the cases all the time like this today, but let's talk about why we want to select BioXclude a little bit. So I'm not comparing specific company, but I use a lot of collagen membrane. Cross-link collagen membrane, non-cross-link collagen membrane. I use a lot. Don't get wrong way that BioXclude only one membrane, I use it. You know, I'm talking about corporate forum here, but I use a lot, all the single companies as well. However, Dr. Paul Rosen always mentioned that when you play golf, you have to have different clubs, right? Same thing. BioXclude would be great. Collagen membrane would be great. Non-cross-link or cross-link, even we utilize the non-resolvable membrane as well. We just have to think when would be the good time, when might be good time. But let's compare a little bit the BioXclude and the non-cross-link collagen membrane, the reason why I like to use BioXclude around natural teeth. This picture tells a lot. So on the left picture, you can see this BioXclude membrane nicely adapted around the bone, but not actually interfering where the root surface is exposed. So intravonic component is already filled. But once you utilize non-cross-link collagen membrane, they get swell a lot once it's hydrated, as well as it's hard to adapt unless your trimming skill is good. Which means that you might spend a while long time just to trim little by little between two narrow space, then just tack in. It's not fitting well, you take it out. Then once non-cross-linked collagen membrane is hydrated, it's hard to trim. Everyone has experience, right? So then if you trim again, if you trim too much, you have to go back again. So it's like, I mean, barely happened, buddy. So then when you look at it more closely, this adaptation of ACM would allow us, or me at least, better flap adaptation compared to non-cross-linked collagen membrane. So this is one of the patients with Dr. Hunt treated for this portion. Then this video, I just want no cut. So I just trimmed the membrane, no specific shape. So we upper right side, gradation tissue removal for the thickness, clean up everything. The bone graft was placed. Then I placed one BioXclude membrane, just cut in half. One side goes in between the tooth, one side, the other side. Then once you stack the membrane between the two teeth, I like to use perio probe, just push a little bit to lingual, underneath the lingual papilla. Just tack under lingual first. Then if blood is still present, the ACM will be hydrated by blood easily. But if not, you can drop one saline there. Once like this. If so, you see that the ACM, BioXclude membrane, starts folding down nicely. Then you can just adjust the position with perio probe. Just adjust the position little by little. Then once mesial side is done, okay, let's do the other side. And the saline was actually affecting the area, so that's why it's more easier just to handle that way. Then adjust the position, look at the lingual side of the papilla, then tack underneath of the lingual papilla. Then once its position is set, adjust. It's very easy for me, no trimming time. For enter this video, no cut, no edit, only 2 minutes. So I'm not sure how long I need to trim collagen membrane around this area, nice shape, then adjust the position. This one allows me just to cut rough shape, then tack inside, then place the position, adjust the position, then get the adjust the position again, yep. If so, it's easier for us to get the primary closure like this. Then when you place flap over it, it's way easier to adjust it. So that's the main reason why, these are main reasons why I like to use BioXclude membrane around natural teeth for periodontal regenerative procedures. But BioXclude membrane can be utilized for many ways. Albert Chen from currently Ohio, at the time Michigan, published this paper at the Clinical Advanced Periodontics. They utilize the bone, ACM membrane as an open wound approach. Raise the flap, place the bone graft, then amnion chorion membrane, BioXclude membrane, you can see smiley face here. They intentionally left exposed. What they found was that they gained the bone. Interesting. Because we know the primary closure is extremely important factor, but ACM can replace this way too a little bit. Again, this is a case series, so it's not fully evidence-based. But when we can use it, our resident Masuma Rizvi last year, actually she was one of the finalists for the BioXclude competition last year. So she had a huge bone loss or large GBL situation for this area. She utilized the DPTK membrane, but many people see this situation, right, within 8 weeks. Membrane exposure happens. But we need to remove the membrane area timing once the recession keeps going on. But when you go back in 4 or 5 weeks, you can still see the bone graft material as bone graft materials. You are concerned about it. So then it's hard for us to get the primary closure because everything is epithelialized inside. So what she did was that she utilized BioXclude membrane over the top at the time of removal of non-resolvable membrane. Then you can see that slightly expose this area. But when you wait for 6 to 8 months, you can get a nice bony feel for this area. So this could be utilized so many ways. If open wound approach is possible, of course, we are not intentionally use this a lot for open barrier, open wound technique, open wound approach. But this type of situation, we need to use something. But this could be a great materials to recover some complication from non-resolvable membrane exposure. Then this is, again, also last year finalist, our resident, Dr. Brittany Wall. She already graduated from this year. What we did was that BioXclude membrane for SPF40 application. Raising the flap, corticotomy is completed, bone graft placement all the way around. As you see that BioXclude membrane adapt to the surface very easily. Then when you see here on the right side, membranes placed, ask assistant, hey, can you drop the couple setting over the top? If so, they adapt by themselves. Very easy handling, which allows us to get a nice primary closure without any challenges. So this is a healing process. Of course, number 10 has to be extracted, had to be extracted due to the ankylosing condition. So based on that, why BioXclude membrane is beneficial for our clinic or patient care? One, barrier function. That's a main basic function as a membrane. Two, promotes cell proliferation. Once those membrane is digested in the body, growth factor, cytokines could be released from the membrane, which helps to promote cell proliferation. Then studies show that possibility of antimicrobial activity because in our natural teeth, a lot of bacteria present, which can, BioXclude membrane digested, once digested, VEGF was found, they will be probably helpful for angiogenesis as well. Then our studies show that cell migration will be increasing. Then, of course, as a clinician, very important factor is excellent handling. Then also, it's very forgiving to membrane exposure. Of course, we try to get the primary closure around natural teeth, but sometimes we couldn't get nice primary closure. The small opening happened, but when you see the BioXclude membrane just there in a week, I feel so comfortable. They granulate faster, then they get epithelialization faster as well. Then, obviously, easy adaptation, as I kept saying, and wound closure is helpful. Therefore, these reasons, BioXclude membrane is not only just a membrane. Also, possibly, we can utilize some directions as a biological modifier, maybe, but we still need more clinical evidence. Majority of studies are animal study or cell levels. We see a lot of ACM papers right now in the clinical advanced periodontics as well as case report as well, the case series. But we are still not fully confident to say that this is best material for the situation due to the lack of randomized controlled trial. So therefore, if any of you are interested in to run that type of study, please talk to the company, not to me. But so that's why, again, I was extremely skeptical at the beginning. I use it, good, paper came out, we did a study, it's actually proving the concept, interesting. It's convincing more and more. Then also, we are helping patients. That's the most important factor as a clinician. So these factors are very important thing for BioXclude membranes. That's why I like to use this for especially mainly 99% time around natural teeth. This is my first choice at this moment. Of course, you can use any other stuff too. But based on that, I would like to thank to all of our residents, colleagues, faculty members. These are our residents who graduated this year, and our period this year. Then these are my 2 kids. So I would like to thank everyone for being here too. Thank you so much for your kind attention.